Hello friends, dear students and my colleagues in physiology and medicine. Here is a short topic. The topic is erythrocyte sedimentation rate, commonly called as ESR. It comes in lots of subjects. For instance, physiology, yes, we have this topic. Then hematology, as in pathology, as a lab method, this is performed. And in medicine, of course, the clinical implication of this investigation, the ESR. So let's discuss this topic in three parts. We will discuss the physiology and biophysics related to the RBCs settling down or sedimentation rate of RBCs. We will describe the lab method, how this particular investigation is performed, and then the clinical application related or clinical application of the ESR. So let's start. First, what is ESR? When the blood is let out of the body and made to stand in a vertical tube, then the RBCs begin to settle down toward the bottom end of the tube, and the rate of settling down of the RBCs is measured and is denoted as erythrocyte sedimentation rate. That's the first point. How is it reported? Very often students make the mistake of saying it is ESR in millimeters per hour. No, the ideal way of reporting is ESR in millimeters at the end of 1 hour rather than saying per hour, because we are going to keep the tube for exactly 60 minutes, the ESR tube, and then the observation will be made at the end of 1 hour, and that will be the final reading. Therefore, we cannot say per hour. We should not be saying millimeters per hour. It should be said millimeters at the end of 1 hour. So, how is it measured? First of all, there are two methods. There are two tubes which can be used. There is Westergren-Katz tube, which is used in Westergren's method, and there is Winthrop's tube, of course, for Winthrop's method. Look, Winthrop's tube can also be used for PCV measurement and for ESR measurement. More commonly, the Westergren method is used. Well, what is the difference between the two? Look, Winthrop's tube is a smaller tube, 10 centimeters or 11 centimeters, whereas Westergren's Katz tube is 30 centimeters, it's long. And the second important difference is Westergren's tube is open at both ends. So, the blood sample is pipetted into the tube, and then immediately the tube has to be transferred to the stand because it's open at the other end. So, that's the difference between Winthrop's tube and the Westergren's tube. Right. What is the anticoagulant used? Well, sodium citrate is the anticoagulant used for ESR measurement. Sometimes EDTA is used as an anticoagulant. So, for the sake of storage of the sample, EDTA will be used, and then when that is being used, then the blood is diluted, the sample is diluted with citrate, sodium citrate, 1:4 parts. 1 part of sodium citrate and 4 parts of blood. That's how the blood will be diluted and then used for ESR. So, however, commonly we can remember it's the sodium citrate which is the anticoagulant used for these methods. The sample is taken and it is transferred to the stand and then left undisturbed, leave it alone for exactly 60 minutes. At the end of 60 minutes, take the reading. Now, what's going to happen is the RBCs begin to settle down toward the bottom end, and there will be a supernatant plasma which will be visible. So, note the column of that visible plasma at the top in millimeters. So, 10 millimeters, 12 millimeters, whatever it is. and that is how you will denote the ESR. So, millimeters at the end of 1 hour. Right. Note a few points related to this method. Test should be carried within 4 hours of collection of sample. It could be 6 hours if the blood was refrigerated or stored at 4 degrees centigrade, but ideally it should be carried out within 4 hours of collection of the sample. RBCs will begin to settle down and the supernatant plasma will be visible, which is separated. So, measure the height of that column of plasma, and that's how we can denote the ESR. What's the normal range? Now look, you will see lots of values for the normal range of ESR. Yes, the values would differ according to age, according to the gender and various other conditions. So let's take the mean values, the averaged out values. The normal range is 0 to 9 millimeters at the end of 1 hour in the case of males and 0 to 20 millimeters at the end of 1 hour in the case of females. It can also be calculated by the formula ESR millimeters at the end of 1 hour, although it's written per hour, which is not the correct way of denoting. This is just written in short. ESR should be less than or equal to age in years divided by 2 in males and age in years plus 10 divided by 2 in the case of females. That's a rough guesstimate or estimate for the normal range of ESR. Females have slightly higher ESR owing to the fact that they have slightly higher levels of fibrinogen. What is the role of fibrinogen? We will discuss it in the theory part. Now, what all problems can occur or what errors can occur because of the method itself? Okay, if the ambient temperatures are higher, the sedimentation is accelerated. So ideally the test should be conducted at the room temperatures in the range of, let's say, 18 degrees to 25 degrees centigrade. But remember, if the temperature is high, the sedimentation rate will be accelerated. Slope of the tube. Yes, the tube has to be exactly vertical. I mean, remember, if the tube is not vertical, what's going to happen? Let's say there is a slope of the tube. This is just a diagrammatic representation. Tube can't be tilted like this, but just to explain, if the tube has a slope, then what will happen is, look, the RBCs, the erythrocytes are settling down because of the gravity. So what will happen is they will settle down very fast on this slope end and then they will settle down. So this accelerates the settling down of the RBCs and therefore the reading would be erroneous. Then after having talked about the method and its errors, now let us see the second part, the physiology and biophysics related to this erythrocyte sedimentation rate. Look, there are 3 stages of erythrocyte sedimentation. It occurs in 3 stages. And the first stage is rouleau formation. Rouleau formation, well, again, this word is pronounced very, very differently in different parts of the world. I guess rouleau is a correct pronunciation. Well, stacks of RBCs are formed. Look, normally the RBCs are flowing in the circulation as single cells. But when they are made to stand in a vertical tube, they will first form the stacks. Stacks of RBCs will be formed and that's called as rouleau formation. So let's say 10 RBCs have formed the stacks. Now remember, a single RBC settling down and stacks of RBCs settling down. This of course will be much faster. So any factor that hastens the rouleau formation, any factor that accelerates the stack formation or rouleau formation will also increase the ESR, obviously. So that's the first stage in the sedimentation. Second is actually the settling stage. The stacks of RBCs begin to settle down, descend down through the plasma, and then the packing stage, about last 10 minutes, they get packed toward the bottom end of the tube. Basically, if we were to discuss the physiology or biophysics behind it, the rate of fall of the red cells depends on the difference in the specific gravity between the red cells and the plasma. So, red cells are settling down because of their higher specific gravity. But then, sedimentation, as I mentioned just now, would depend on how fast the rouleae are formed. The stacks are formed. How fast are they formed? Because, as I mentioned, rouleae would settle down faster as compared to individual RBCs. So, let's talk something about this rouleae formation. Now, in the circulation inside the body, the RBCs have in their membranes negative charges. On the surface of the RBC or the membrane of the RBCs, there are these negative charges, and this negative potential has been referred to as zeta potential. And this zeta potential, the negative charges, do not allow the RBCs to come together while they are in circulation. So, remember, zeta potential on the RBCs, it does not allow the RBCs to come together when they are in circulation. But when blood is made to stand in a vertical tube, what happens is there are certain factors in the plasma which overcome this zeta potential, which allow this zeta potential to be overcome, and then the RBCs will come together to form the rouleae, or rather rouleae formation will be hastened because of those factors in the plasma. So, remember, there are these pro-sedimentation factors in the plasma which will hasten the rouleae formation and therefore increase the ESR. So, remember, a very important factor is the rouleae formation so far as the changes in ESR or influence on the ESR is concerned. Right. Now, that brings us to the key cardinal question. What are those factors which hasten the rouleae formation? Remember this term forever now. There are asymmetric macromolecules in the plasma. If there are increased asymmetric macromolecules or macroglobulins in the plasma, they are the ones which will hasten the rouleae formation. And if the rouleae formation is hastened, ESR will increase. So, remember, any condition that increases these asymmetric macroglobulins in the plasma, most important being fibrinogen. Then also there are gamma globulins in the plasma. If they increase, you know, gamma globulins, the immunoglobulins can increase in a variety of conditions. So, whenever they increase, or if increase in the fibrinogen in the plasma, the ESR will increase because rouleae formation will become faster. So, fibrinogen, gamma globulins, acute phase proteins, you know, in inflammatory condition, the acute phase proteins may also increase in the plasma. C-reactive protein, which is most commonly employed to detect certain conditions, if that's present, then ESR would increase. But remember one more thing at this stage, and this is very important. So, let me just highlight it here. Rouleae formation is retarded by albumin in the plasma. It's retarded, it's not hastened by the albumin in the plasma. So, remember, increase in the albumin in the plasma would decrease the ESR, and decrease in the plasma albumin would increase the ESR. Okay? Note this point very clearly, and let me tell you the clinical condition as well. nephrotic syndrome. Now, this is a renal disorder, the condition related to the kidneys. What happens in the condition is that the plasma albumin is lost into the urine, and therefore the plasma albumin decreases, and therefore the ESR will increase. So, please remember, I mentioned all the other proteins in the plasma. If they increase, they hasten the rouleau formation, overcoming of the zeta potential and faster rouleau formation, and therefore increased RBCs. Except one plasma protein which has got an inverse relationship. I mean, if the plasma albumin increases, it will retard the ESR. If the plasma albumin decreases, which happens in the nephrotic syndrome, then the ESR will increase. So, remember this because it has got a clinical application. There are other factors like blood viscosity. You know, for example, viscosity increases in polycythemia. If the RBC count has increased and has tremendously increased, I mean, it's a polycythemia, then the ESR will be retarded, it will decrease. Whereas on the other hand, if there is anemia, ESR will increase. Now, that's very obvious, I mean, easy to understand. If there is anemia, reduced RBC count, and relatively there is more plasma, then the settling down of RBCs can occur faster. The rouleau formation and settling down, because then, you know, there are lesser number of RBCs relative to the plasma, and therefore there is less viscous resistance for the RBCs, and therefore in anemia the ESR will increase, but in polycythemia the ESR will decrease. There is a lot of crowding of the RBCs, and therefore there will be some form of resistance for the RBC settling down. So, let us now look at the third part, and that is clinical application. We talked about the method, we talked about the physics involved in the settling down of RBCs. Now, let us finally talk about the clinical application. Now, first of all, try to understand that the ESR does not have much of a diagnostic significance. Yes, because ESR increases in hundreds of conditions. So, you can't diagnose a condition only on the basis of ESR observation. Then what is the importance of ESR? Let us first look at the conditions. ESR increases in inflammatory conditions, and there are lots of such conditions: collagen disorders, autoimmune diseases, rheumatoid arthritis, and so on and so forth. Chronic infections, tuberculosis, very commonly, in fact, this investigation was first employed in the cases of tuberculosis itself. So, very often you will find that the ESR has gone up, and it is in excess of 100 millimeters at the end of 1 hour. So, tuberculosis and chronic infections, in some malignancies also. ESR decreases. Now, that's not very clinically significant, because anyways we have said ESR is 0 to 9 millimeters. So, decrease will be, how far significant would it be? But anyways, it can still decrease in certain conditions such as sickle cell anemia, because there is sickling of the RBCs, RBC's shape has changed, and therefore the stacking of RBCs is impaired. The rouleau formation or stacks formation of the RBCs, that gets impaired, and therefore the ESR decreases. Heart failure, polycythemia, which I already mentioned, leukemia, when the WBCs have increased. So, in all such conditions, ESR decreases. However, that's not of much of a significance. We will be more interested in looking at increase in the ESR. So, as I mentioned, if it is going to increase in these hundreds of conditions, what is the clinical importance? Well, it has got prognostic value or prognostic significance. What do I mean by that? It's about the progression of the disease. So, let's say a patient of tuberculosis and you have diagnosed it just now, and the ESR is in excess of 100 millimeters at the end of 1 hour. Well, then you start the treatment, and maybe after 2 or 4 months, ESR is repeated every 2 months. Treatment is going on. And if you find that the ESR has now come down to 60 millimeters or 40 millimeters at the end of 1 hour, it indicates a good disease outcome. Prognosis is said to be good. I mean, disease condition is improving. That's the value of ESR. On the other hand, if you have started the treatment and you are performing ESR periodically every 2 months, and if you see that ESR has not decreased, or in fact it has gone further higher up, you can, the disease outcome may not be that good. Patient may not be taking treatment. There are lots of factors associated with it. So, it is indicative of the prognosis of a disease over a period of time. That's the significance. So, these are, that's the clinical importance. And therefore, let me just sum it up again. In summary, 4-5 points to be remembered if you are appearing for some university exam. One is define ESR, it's the settling down of RBCs. Second term that you should remember, rouleau formation. Stacks of RBCs are formed and they settle down faster as compared to individual RBCs. So, any factor that hastens, accelerates the rouleau formation will hasten or increase the ESR. That's the second thing. Third point that you should remember and must be there in your university answer is asymmetric macroglobulins in the plasma. So, fibrinogen, gamma globulins and other such acute phase proteins. If they are increased in the plasma, the ESR does increase. Fourth condition, fourth point that you should write down in your answers is Wintrobe's method, Westergren's method and the tubes, and you can even draw the diagrams. Remember, Westergren's tube is open at both ends. And then the normal values of ESR, the clinical conditions in which increases, and the final point that you may double underline and highlight is the importance of ESR is more of prognostic rather than diagnostic. So, these are some of the points related to this lab investigation and its importance.